Good morning. Welcome to the John T. Matham Memorial Hospital Total Joint Replacement class for the patient and their family. Total joint replacement at Matha Hospital is your journey to active living. You get back into the swing of things. It relieves the burden of knee and hip pain. On this slide, you see your healthcare team. At Matha Hospital, we practice patient-centered care, and you're always the center of the care. The orthopedic surgeon performs the surgery and follows you throughout your healing process. The case manager or social worker prepares you for discharge. They set up home care with a visiting nurse and physical therapy. They also obtain needed equipment for you. Nursing is continuously assessing you and keeping you safe. They medicate you for pain. They give you education to prevent complications. They coordinate the care with physical therapy and occupational therapy. And nursing again keeps you safe because they make hourly rounds on you. Physical therapy prepares you for a safe discharge. They make sure that you can independently ambulate with a walker, negotiate stairs, and safely perform strengthening exercises. Occupational therapy helps you perform your everyday activities. For example, self-care techniques like getting dressed in the morning, mobility and transfers, and they give you tips on home safety. And anesthesia puts you to sleep for surgery. They prescribe pain medicine, and they check on you post-operatively to ensure that your pain medication agrees with you and that it is effective in relieving your pain. The agenda for this program is what is a unicompartmental knee replacement. That is a partial knee replacement or unicondylar knee replacement. What is a total knee replacement? How's it done? Who's it for? The risks, the physical therapy. The unicondylar knee replacement is partial knee replacement. The diagram on the left side shows a full knee. It shows the femur or the thigh bone, and at the bottom shows the tibia. It shows you the patellofemoral component, the medial compartment, and also the lateral compartment. Those are the three portions of the knee. The right diagram shows you a total knee replacement versus a unicompartment knee replacement or partial knee replacement. With a partial knee replacement, they are only going to replace the part of the knee that is arthritic. Partial knee replacement. Osteoarthritis is in only one component of the knee, either the lateral, the medial, or the patellofemoral. Partial knee replacement advantages are quick recovery, less pain, less blood loss. Disadvantages is a possible infection, possible blood clots, possible nerve damage, and a possible reaction to the animal. What is a joint replacement? It's also known as a total joint arthroplasty. The bone of the joint is replaced with the metal, plastic, or ceramic. On the left-hand side, the picture shows a damaged knee. You can see the damaged cartilage and also the bone spurs. On the right side, you see a beautiful knee replacement. Osteoarthritis causes degenerative joint disease. It affects the cartilage lining on the ends of the bones. Cartilage becomes worn, no longer allowing smooth movement inside the joint. Painful grinding sensation as the joint works, and pain, stiffness, and loss of function are very common. The knee joint. The knee joint is formed at the meeting of the point of two major leg bones, the femur and the tibia. The femur is the thigh bone, the tibia is the shin bone, and then you have the patella, which is the kneecap. On this diagram, you see three slides or x-rays of the knee. The first slide on the left-hand side shows a beautiful knee. There's a beautiful space between the femur and the tibia, and also the bone is nice and smooth. In the middle, this x-ray shows a very old arthritic knee. You can see bone on bone. On the right side, you see a beautiful knee replacement. It looks a lot like the picture on the left side, which shows the beautiful knee, the space between the femur and the tibia, and this bone is nice and smooth. This is the hip joint. The hip joint is a ball and socket joint. The femur is made up of the thigh bone, the femoral head, and also the femoral neck. The acetabulum is the socket. Now, this picture shows three x-rays of a hip joint. The first one is the head of the femur. It goes into the pelvis. That hip does not need surgery. The picture next to it shows you a pelvis with two hip joints. As you can see, both hips are deteriorating and damaged, and they look like they're bone on bone. The bottom picture shows you two hips that have been replaced with a hip replacement. A total shoulder replacement replaces the damaged bone and cartilage with a metal and plastic implant. The shoulder joint is a ball and socket joint, much like the hip joint. The ball is the top of the arm bone, which is the humerus, and the socket is within the shoulder blade. It's called the scapula. Ankle replacement is the ankle is approached from the side or the front, depending on the type of implant. The Achilles tendon examined probably needs to be lengthened to improve the range of motion of the ankle with an ankle replacement. A period of non-weight bearing allows the implants to heal in place. This picture on the left side shows you a beautiful placement of an implant. You see the tibia, the ankle prosthesis is placed right at the bottom of it, right on top of the talus. And the right-hand side, you see the Achilles tendon, like we said on the slide before. The Achilles tendon has to be lengthened to ensure proper range of motion. Controlling your risk factors. You have to inform the surgeon if you see a specialist on a routine basis or if you have been following a physician for a prescribed diet. You have to review all your medications with your surgeon, including herbal supplements, vitamins, and/or minerals. Check with your surgeon regarding blood thinners, for example, Coumadin, Aspirin, and Plavix, and when you should discontinue them before the surgery. Controlling risk factors. If you're overweight, lose weight. It will help reduce the pressure on your joints and reduce your pain. If you're diabetic, follow your diet. Check your blood sugars at least twice daily and take your medicine as prescribed. If you're a smoker, please stop smoking as soon as possible before the surgery. This will decrease chances of lung problems and assist you in your speedy recovery. Also a reminder, John T. Mather Hospital is a non-smoke hospital or smoke-free hospital, and you will not be allowed to smoke here. Pre-op checklist. What to bring the day of surgery. A copy of your healthcare proxy, eyeglasses with a case, dentures. We provide you with a denture cup, hearing aids, personal toiletries, lightweight bathrobe, telephone numbers, credit card, and a small amount of cash. I wouldn't bring more than $20, maybe to buy a newspaper. Pre-op checklist continues. You want to check for possible discharge transport fees, a book or a magazine, a laptop computer. We do have Wi-Fi. Loose-fitting pants, shorts for the hospital stay and/or rehab unit, and pair of sneakers, non-skid shoes, or closed-back non-skid slippers for the hospital stay and possibly the rehab unit. Most patients today go home. Preoperative assessment, pre-surgical testing. Pre-surgical testing takes place in the Cody Pavilion, which is at the back of Mather Hospital. Pre-surgical testing, you want to call for an appointment as soon as you know you're having a surgery and the date that you have planned for it. The phone number is 631-476-2835. Bring your bottles of prescription medications. That includes vitamins and herbals. No fasting is required. Allow 2 hours for appointment. Bring your CPAP or BiPAP settings and a mask type if you have sleep apnea. Everyone needs a medical and a dental clearance. If you need more than that, for example, a cardiac clearance, we will let you know. Have your insurance information available, and you'll meet your physical therapist at this appointment. Day before surgery, you want to drink plenty of fluids, eat well-balanced diet, no solid food after midnight, clear liquids up until 2 hours before arrival to the hospital. Pack a bag for the hospital. The hospital will contact you about your arrival the day before surgery, usually between 2 p.m. and 6 p.m. If you have surgery on a Monday, the day of surgery, you want to do clear liquids up until 2 hours before arrival to the hospital. No solid food after midnight, the night before. Take only the medications instructed by the nurse in pre-surgical testing with a sip of water. Report to the Matthew J. and the Deborah A. Cody Ambulatory and Inpatient Surgery Pavilion. Inpatient Surgery Pavilion. You come right in, it's in the Cody Pavilion. You come in, report to the front desk. You will be escorted into a private room. An ID bracelet will be placed on you. Your name and date of birth will be checked with the nurse. You will change into a hospital gown. You will meet the nurse and an IV will be started. You will speak with the surgeon, anesthesiologist, and the operating room registered nurse. Anesthesia. Anesthesia for the total joint arthroplasty or replacement procedure. You will see the anesthesiologist preoperatively for an evaluation. Intraoperatively, he will be with you in the OR at all times at the head of the bed. And postoperatively, he will control the pain management after surgery. Anesthesia on the preoperative day. When you're in ACU before surgery, you will get a preoperative evaluation from the anesthesiologist. He will review all your medical and surgical history. He will review with you any difficulties you have with anesthesia in the past, and he will talk to you about which anesthesia is the best for you. The intraoperative care period is when the anesthesiologist is with you in the OR. There are three choices of anesthesia that they use. General anesthesia with a PCA. They actually put medication through the IV. You are completely asleep and they put a tube down your throat. Spinal anesthesia is where they take a catheter and put it in the lower part of your spine. They numb you from the waist on to your feet, and then they take the catheter out. Now, an adductor canal block is only used for a total knee replacement and a partial knee replacement. The adductor canal block numbs the top of the knee, the sides of the knee, and most of the pain from the back of the knee. You will receive also general or spinal anesthesia with an adductor canal block. You just don't receive an adductor canal block with a total or partial knee replacement. Postoperative management. Anesthesia follows you with postoperative care unit, which is the PACU. And also on the surgical floor, they want to make sure that the pain medicine agrees with you and that you are comfortable. While you are sleeping, the surgeon actually calls your loved one that you have identified, and he tells them how the surgery went. And your family and friends can wait in the waiting room. Post-anesthesia care unit. This is called PACU or recovery area. It provides care for patients who are recovering from anesthesia. The registered nurse in PACU will be with you on a one-to-one basis for the first hour. They are highly skilled and a knowledgeable staff. They monitor your blood pressure, your heart rate, and respirations. They treat you postoperatively for pain or nausea. They manage your postoperative pain. They check your dressing. They make sure sensation does return and you have full circulation in your extremity. Orthopedic Nursing Unit. The Orthopedic Nursing Unit at Mather is 3 South. This is a designated nursing unit just for orthopedic patients in our total joint program. The staff is well trained in the total joint replacement care for a patient. They do ongoing assessments, preventing complications. They do a lot of education with that. They medicate you for pain. They coordinate the care with your physical and occupational therapists. And at Mather, you are safe. The nurses do frequent hourly checks by rounding. Preventing complications. With a total joint replacement procedure, infection is the #1 complication that we try to prevent. You are given Hibiclin soap in pre-surgical testing. You will be expected to take preoperative showers and use it from chin to toes. You will be expected to do this 2 nights before the procedure, the night before the procedure, and the morning of the procedure. Prophylactic antibiotics is given to you through the IV for 24 hours. All employees practice standard precautions to keep you safe from infection. Blood clots. We try to prevent blood clots also. We give you blood thinners, for example, Lovenox, Coumadin, Xarelto, or enteric-coated aspirin. Most people are given enteric-coated aspirin twice a day. 2 weeks for a knee replacement, 4 weeks for a hip replacement. You are going to be wearing intermittent pneumatic compression stockings in the hospital with thigh-high anti-embolism stockings. This helps promote circulation and prevent blood clots. You're also going to do mobility and leg exercises, and you are out of bed the day of surgery. We prevent also pneumonia by using the incentive spirometer. You cough and deep breathe, and early mobility and out of bed also helps with prevention of pneumonia. Anticoagulation therapy or blood thinning. It keeps your blood from making clots, helps your blood flow more easily. Have blood tests as directed by your doctor if you're on anticoagulant, for example, Coumadin. Never skip a dose, never double dose, and take medication at the same time as directed by your physician. Call your physician if you have red, dark, coffee, or cola-colored urine, bowel movements that are red or look like tar, bleeding from the gums or nose that does not stop quickly, vomit, coffee-colored or bright red. Anything red you cough up, severe pain and headache or abdominal pain, a serious fall or that you hit your head, dizziness or weakness. Hospital stay at the hospital is only 1 or 2 surgical days now. Most people are going home. You are transported to the hospital room from the OR. You rest in bed. All patients will be getting out of bed with assistance the evening of surgery, and blood thinners are prescribed and an IV antibiotic is given. This is the day of surgery. Pain scale. At Matha, we use the pain scale of 0 to 10, 0 being no pain and 10 being the unbearable worst pain you can ever think of. Pain control at John T. Matha Hospital. You're controlling your pain in a safe and effective manner is a top priority for all our patients. All surgery results in pain, but we will work with you to control your pain through medication and non-medication techniques. For example, ice, distraction, relaxation, and repositioning. Our goals is to get you to the comfort function goal. This is the number on the 0 to 10 pain scale where your pain and the side effects of the pain medication doesn't interfere with physical therapy or daily activities. Our goal is to improve your level of function and reduce the negative side effects that can result from pain medication. Drowsiness and complication are two common side effects. We are a team. Initially, we will be managed by the acute pain service, and then chronic pain management can work with the acute pain service for pain that is more complex. If you feel your pain is not well controlled, please speak with your doctor, the joint coordinator, or your nurse. Many patients who undergo surgical intervention for joint replacement have lived with chronic pain for a long time. If you have a chronic pain and have been on pain medication prior to surgery, please let us know so that we can work with you to ensure that your pain is adequately managed. Postoperative day 1 for knee replacement. We make sure that your pain management is adequate, that your safety concerns are addressed. We help you with AM care and getting dressed. Some patients will use a knee immobilizer if you can't do a straight leg raise by yourself, but don't worry, physical therapy comes in and assesses you, and they give you instruction on that. Physical therapy comes in twice daily, once in the morning and once in the afternoon to work with you. Occupational therapy comes in on post-op day 1 and gives you instructions on how to do your daily living activities, for example, getting dressed, and also they give you tips on home safety. Physical therapy, when they get you up, they walk you as far as you can with a walker, they assist you to a chair, and they instruct you on exercises. You're also going to have pneumatic compression stockings with anti-embolism stockings. Again, both of these devices help you with circulation in your extremity. They prevent blood clots. You're going to use an incentive spirometer every hour or two to prevent pneumonia. You're going to continue your exercises that PT taught you. Some people have a Foley. It's discontinued post-op day 1. A Foley is a catheter that goes into the bladder and drains urine. If you have one, don't worry about it. We take care of it. If you don't have one, don't worry about it either. And you have a case manager that comes in post-op day 1 and takes care of your discharge planning. Post-operative day 1 for a hip replacement, your pain management is addressed. Safety concerns are also addressed. We assist you with AM care and getting dressed. With a hip replacement, you have an A-frame pillow that is between your legs. It reminds you that you had a hip replacement and you cannot cross your legs. Occupational therapy comes in and shows you how to do your daily living activities, for example, getting dressed with hip precautions. They'll instruct you on that. Physical therapy comes twice a day, once in the morning, once in the afternoon, and they get you out of bed. They walk you with a walker. They bring you back to your room. They assist you in the chair, and they show you how to do exercises properly. You also are going to have pneumatic compression stockings with anti-embolism stockings. Again, both these devices promote good circulation and prevent blood clots. An incentive spirometer you will use hourly, and this is to prevent pneumonia. You can continue doing your exercises that you've been instructed. Some people have a Foley catheter. This is a catheter that goes into the bladder and drains the urine. If you have one, don't worry, it gets discontinued post-op day 1. If you don't have one, don't worry about it. And the case manager comes in post-op day 1 for you to go over your discharge planning. Post-operative day 1 for a total ankle replacement. Your pain is well managed. Your safety concerns are addressed. The nurses will assist you with AM care and getting dressed. Physical therapy comes and works with you twice a day, once in the morning, once in the afternoon. Occupational therapy is initiated They help you with your daily tasks of living and also how to get dressed since you had an ankle replacement. Physical therapy will assist you in ambulation with ankle precautions. Again, you will have non-weight bearing for a period of time. And they show you how to ambulate. They assist you to a chair. You'll have pneumatic compression stockings on. Again, pneumatic compression stockings are to promote good circulation, prevent blood clots. You'll use the incentive spirometer every hour. This is to prevent pneumonia. They will continue the exercises that you are instructed, and a case manager will set you up with home care for discharge, for your discharge care. Post-operative day 2, knee and hip replacement. Your pain is well managed. AM care and dressing you will do with assistance. You're sitting in a recliner chair. You walk to the bathroom with assistance utilizing a walker. You'll have a raised toilet seat that will be provided for you by the hospital. Physical therapy and occupational therapy is continued. Again, safety is always our main concern. Post-operative day 2, the case manager comes in and wants to finalize all your discharge plans. A significant other should be available to come in for a discharge class at 1 p.m. the day of discharge. Your discharge plans will be confirmed, home with home care, traditional care unit, which is our TCU here at Mather, or skilled nursing rehab center. Again, most of our patients are going home with home care, which the social worker sets up. Prepare for discharge. You want to prepare your home. You want to buy food ahead of time. Prepare meals and freeze them. Have a family member or friend assist with chores and feeding animals. Have someone come in and check on you the first few weeks if you are by yourself. And then you get discharged home.
Hello, my name is Anna. I'm one of the registered dietitians at John T. Mather Hospital. You will also be seen by one of us. Nutrition is a very important part of your recovery as well with your total joint replacement. So as Marianne said before, nutrition pre-op, you want to follow a diet recommended by the doctor. So if you have a history of diabetes, make sure you're watching your blood sugar levels. Make sure you're eating well-balanced meals. If you have any other past medical history, such as cardiac disease, make sure you're trying to follow a well-balanced diet as well. If you have any questions about this, definitely let us know while we're here. We're a wealth of information, so we want to get that for you. It's very important to maintain proper nutrition before surgery. Make sure you're staying hydrated. Make sure you're eating well. As Marianne said before, no solid food past midnight the night before, and clear liquids 2 hours before you're due in. So if you're due in at 8 a.m., no clear liquids before past 6 a.m. And what is a clear liquid? It is black coffee, black tea, or water. Nothing, no sugar, no milk, nothing like that in there. Just black coffee, black tea, and water. And also no herbal teas. Your nutrition post-op, you're going to be prescribed a diet based on your past medical history. If you have a history of diabetes, we're going to probably have you on a consistent carbohydrate diet. We will go over with you what that is, but mainly we want everyone eating well-balanced meals, watching their blood glucose levels, and making sure you're not having any nausea. We're going to be asking you along with nursing, how is your pain? Are you having any nausea? Are you tolerating your meals? Do you have any questions when you get home on how to follow a certain diet pattern? Constipation is also a side effect. So if this is a occurring situation for you at home, let us know. We do have great handouts, and we want to just make sure you're drinking enough fluids, getting fiber in your meals 3 times a day. That way you're going to make sure you're going to be feeling better. This slide is just on healthy weight. So if maintaining or obtaining a healthy weight is important for you, we have a lot of information on that. We understand it's very hard post-operatively to go on a stringent diet, so we just want to make sure that you're eating well, you're doing well in the hospital, because we want you recovering as much as you can. This is a great website. If you want to use this, choosemyplate.gov. We have a bunch of other websites and information that we can use for you. And lastly, medications. So if you are to be receiving a blood thinner called Coumadin, it does interact with the vitamin K in your body. So we will be going over the Coumadin drug-nutrient interactions. But if you're not prescribed this, we won't have to worry about this. And if you have any other medications you take, any other drug-nutrient interactions, or any food allergens, please let the nursing know beforehand, but also let us know if you have any questions. And thank you so much.
Hi, my name is Lisa Malcolmson, and I'm the Director of Rehab Services here at Mather, and I will be discussing your physical therapy and your occupational therapy care while you're here. So on the first day, we will be seeing you. So the day of surgery, a physical therapist will come up and see you either on the nursing unit or in the recovery room, depending on where you're at the time of day. If for some reason you come up very late or your surgery is late, we will see you the next morning, and the nurses will get you up and start to walk with you. But if not, we get you up and we start walking, take you to the bathroom, and start to get you going. Our goals, our physical and occupational therapy goals. So we're preparing you for a safe discharge. So from the minute we meet you, we're thinking about when you're leaving us. And what we would like you to be able to do is go from a lying position to a standing position all by yourself, to be able to walk for approximately 150 feet, to be able to get to the bathroom and the kitchen at home with an assisted device, which is typically a rolling walker, but again, doing it all by yourself. Be able to perform all your exercises and self-care activities independently and safely. If you've had your knee replaced, to bend your knee to 90 degrees or more. And if you have stairs at home, to be able to negotiate those safely. Anti-embolism exercises. So these are some exercises that you are going to be doing while you're here at the hospital. You can do them every 20 minutes when you're awake, or another thing I like to gauge is when you're watching a television show, when the commercial comes on, pick an exercise and do that exercise the entire commercial. And then when the show comes on, obviously relax and watch the show, and the next time the commercial comes on, do the next exercise. So the first one is called ankle pumps, and you can pump your ankles up and down. You can go side to side like windshield wipers. You can go in circles. You can even get fancy and with your big toe write letters in the air just to get those ankles moving and pumping the fluid out of your legs. The second one is called a quadriceps set. So you are going to tighten your knee muscle or your quadriceps. So basically you're going to take your knee and push it into the bed, tighten it, hold it for a count of 5, and relax, and do a set of 10. And then the last one is called a gluteal set, and that's squeezing your bottom together, holding it, counting to 5, and relaxing. Again, you could do that for a set of 10. Deep breathing exercises. This is an incentive spirometer. You'll receive one here when you're at the hospital. We ask you to take 10 deep breaths per hour. So you take a deep breath in. When you're actually looking at the device here, the yellow ball in the picture, ours is actually blue. But you're going to be taking a deep breath, holding it for 10 seconds, and relaxing. What this does, it helps to inflate your lungs, helps to get the anesthesia out of your body, and it helps to prevent a pneumonia. Equipment that you will see here. Everybody will get Flotrons, and that's the top center picture. Or they're also called pneumatic compression stockings. They go on your legs, and they blow up on their own, and then they relax. It helps to get the fluid out of your legs. The bottom pictures are if you're having a hip replacement. You will wake up in the recovery room with a pillow in between your legs because you do have precautions, which we'll talk about in a moment. So you can have them in between when you're lying in the bed or sitting in the chair, and it's called a hip abduction pillow. If you're getting your knee replaced, you do not have any movement precautions at all, so you do not have to worry about this. If you are having your hip replaced, and there's 2 different approaches, you should ask your surgeon which approach he is going to perform the surgery. So for a posterior approach, you cannot cross your legs, you cannot rotate your legs inward, and you cannot sit at less than a 90-degree angle. And we have some pictures to show you exactly. So here is one of the hip precautions, and not to cross your legs. So obviously if you're laying on your side, you need to have a pillow in between, or if you're laying on your back, you need a pillow, as in the picture all the way on the right. We do not want you crossing your legs at all. The next picture is, again, do not rotate your legs inward. When we lay in bed, most of us have a natural external rotation component, which means your legs are turning out. You just don't want to turn your legs in. You also have to remember this in standing. You don't want to do any pivoting on your hips. So when you are turning and standing, you want to turn as one unit for a while until your surgery heals. And the last one is do not bend forward beyond 90 degrees. So if you look at the picture on the left, she's bending down and picking something up from the floor. But if you look at her hip, she has an acute angle, less than 90 degrees. So she could potentially dislocate. So we don't want you to do that. And in the next picture, she has her feet on a step stool, which again, if you look at the hip, it closes down that angle less than 90 degrees. Again, could put you at risk for a dislocation. The last picture on the right, she's in a obtuse angle, so not near 90 degrees, and she has her pillow in between her leg, and she is in good form. Movement precautions if you are having an anterior approach to your total hip replacement. You're not to bring your leg backwards, so you're not going to bring it into extension. They do not want you to rotate your leg outward, and they do not want you to bring your leg out to the side. So if you're standing, they don't want you to bring your leg out to the side. And again, your surgeon will let you know how long you have to have these precautions, and he will let you know when you're able to safely do the activities as you did before. So physical therapy for your shoulder, again, on the day of surgery, we come and see you and we perform some passive exercises. So those are exercises that we do as the therapist. In the procedure, the therapist will gently also move your shoulder in the preset range that the surgeon has told us to help you to prepare your movement for the future. And also you'll learn some activities that you can do for your hand, your wrist, and your elbow for when you go home. Pain management and physical therapy. The therapists speak with nursing prior to us seeing you. We discuss with them a specific time so that you can be medicated ahead of time, so that when you're in your physical therapy session, you can get the most out of it. Once the surgeon does his fantastic job of giving you that new hip or knee or shoulder, now it's really up to you to get up and start using that joint. So always communicate your pain levels. Try to keep your pain level below a 4. Research has shown that if you keep it below a 4, it's easier to manage your pain. Exercise and movement is key for pain management. Most people don't want to move their leg when they are in pain, but what ends up happening if you don't move that leg, in a day or two, when you decide to move that leg, it can become more painful. Exercise helps to pump the swelling and the fluid out of the area and gets the muscles contracting and working on strengthening faster. And cold therapy, I'm sure most people at home have had cold packs. It helps to alleviate the inflammation in the area, and it also has an analgesic effect. And we have those here at the hospital, and you will get a cold pack here and use it several times a day. Outpatient physical therapy. At some point during your rehabilitation, you will need to see an outpatient physical therapist. We do have a site here through the hospital. It's located across the street. It's at 301 Oakland Avenue. If you walked across the street from the hospital, it's right there. It's a state-of-the-art facility, convenient parking. We have one-on-one therapy, and it's a real friendly and fun atmosphere. We would love to see you at our Mather Outpatient Physical Therapy, but I do want to let you know that you're going to be going at least 2 to 3 times a week, and you're going to be there for about an hour to an hour and a half. If you live far away, you may want to look at a place closer, or if you have to have a friend drive you, you want some place that's a little bit more maybe convenient for you. I suggest to all of the patients to Locate a physical therapy facility prior to your surgery that's close to home that you're comfortable with, so that once you've had your surgery, you don't have to think about this piece until the doctor or the home care therapist says you're ready for outpatient, and then you can just call them and make your appointment. Occupational therapy. Excuse me. I like to call our occupational therapists our ADL specialists, our activities of daily living specialists. And what that is, those are activities that we do all day long that we don't think about. There are lower body dressing, so getting dressed, bathing, grooming, toileting, doing some light homemaking. Again, all the things that we do all day long that we don't think about, you'll still be able to do, but it's just going to take you a little bit more time. Some of you may need assistive devices to help you perform those activities. You might need a commode because your toilet seat might be too low, and if you've had a hip replacement, you could potentially break those precautions, so you may need a commode. A long shoehorn to grab things, to get your shoes on when you can't bend over, and a reacher. If something falls on the ground, you may need a reacher. We have all that equipment here, and we will teach you how to utilize it, and Brandon, the social worker, can order it for you prior to discharge. OT also works on mobility and transfers. They work on getting in and out of the bed, on and off the toilet, in and out of the shower tub, and in and out of a car. We also talk a lot about home safety, and we even would like you to start getting your home safer even now. So think about your stairwells. Are those railings safe? Are they wiggling a little bit? Are they in a stud? You want to make sure that those railings are nice and strong because you're going to be relying on them when you're going up and down the stairs. So make sure that they are secure. If you need an extra railing, you might want to put one in. Think about your shower. Think about do you need any grab bars in the shower? You may want to have them installed prior to surgery. Also, grip surfaces in the shower or tub. The shower can be a dangerous place in and of itself. Now, you're just recovering from surgery. You want to make sure that you have a grip surface on the bottom of the tub or even one of those bath mats so that you don't fall. We also ask you to take away any of your throw rugs. Just roll them up, put them in the garage, the attic for a little while. Most of you will be discharged with a rolling walker. Sometimes that walker gets caught on the edge of the rug and people can fall, and we don't want anybody to fall. So if you could just put those throw rugs away for now, they will come out in a few weeks to months, and you can utilize them again. But for right now, for safety, let's put them away. Also, think about your shoes. Make sure you have a good supportive shoe that has a non-slip sole. Sneakers are the best, but if for some reason you don't like to wear sneakers, again, a nice supportive shoe that has a non-slip sole. And also start thinking about keeping some items within reach. If you have a certain pasta dish that you use and it's always on the top shelf of your cabinet, why don't you just start lowering them so it's a little bit easier during this time of recovery. And again, these are our goals. They are the same ones that were in a previous slide. And again, we're preparing you for a safe discharge. We want you independent, going from a lying down position to a standing position. Again, walking independently about 150 feet with an assistive device, which typically is a walker. Be able to perform your exercises and self-care activities safely. Be able to move safely within your precautions. Bend your knees 90 degrees or better. And again, to be able to negotiate the stairs safely. Thank you.
Hello, I'm your case manager, Brandon. As your case manager, I'll be setting up your discharge plan. Depending on your physical and clinical status, you will be discharged 1 to 2 days after your surgery. Your progress and readiness for discharge will be assessed daily by your physician and interdisciplinary team. As your medical case manager, I will visit you the day after your surgery, develop a personalized discharge plan, assist you with any insurance questions, and make all of the discharge arrangements. Once you are discharged, your physical therapy will continue. Based on your physician's and therapist's recommendations and any insurance authorizations, you may be discharged to home with therapy or outpatient physical therapy and durable medical equipment. We also have the transitional care unit and subacute rehabs in a skilled nursing facility. Our team will verify your insurance eligibility and benefits. Your physician will be contacted if pre-authorization is required. You will be notified if there is any copay. This is the number if you have any insurance questions or financial questions. The program goals are the reduction of pain, removal of assistive devices, improved motion, improved function, return to work, sports, and daily activities, improved quality of life, and the goal is for patients to be very happy and grateful they had the surgery. Your success in regaining your ability to do the things you love is very important to us. Please let us know if there is anything we can do to help ensure you receive exceptional care. We look forward to caring for you. Thank you for choosing John T. Mather Memorial Hospital for your total joint replacement.